Hi everyone, my name is Michelle Ibrahim. Today we'll discuss coronavirus infection in pregnant women. COVID-19 and pregnant patient overview. COVID-19 infection, coronavirus diseases 2019. It is an acute respiratory disease caused by novel coronaviruses SARS-CoV-2 CDC 2020 March 20. Many physiological and anatomical changes of pregnant affect the respiratory system and increase susceptibility to infection in general, which may complicate or delay the diagnosis of COVID-19 and or clinical course of the diseases in the infected women. Respiratory illness during pregnancy may be associated with increased infectious morbidity and high maternal mortality rate, but it's currently unknown if the pregnant women have more severe disease as a result of COVID-19 infection. Initial evaluation and the management of pregnant women with suspected or confirmed COVID-19 depend on the presence of symptoms, severity of symptoms, and the clinical and social risk for COVID-19 infection. Screening for COVID-19 in pregnant patients is similar to that in the general population. Follow general recommendation for infection prevention and the management of pregnant women with suspected or confirmed COVID-19. Management of infectious in pregnancy in women with suspected or confirmed COVID-19. There is no specific antiviral treatment to COVID-19, but supportive care may help to relieve symptoms and should include support of vital organ function in severe case. Consider the mental health need for pregnant women during the COVID-19 pandemic. Consideration for routine prenatal care during the COVID-19 pandemic. Unless directed otherwise by local clinical policies, women should be advised to attend routine antenatal care unless they meet criteria for self-isolation, in which cases appointments should be deferred for 14 days. Screening for COVID-19 symptoms and the possible exposure prior to having patient reported for in-person appointment. In patients with certain high risk obstetric condition and or comorbidities should be provided appropriate and necessary prenatal care and antenatal surveillance when indicated. Consider alternate prenatal care approaches to help control and spread of COVID-19, including patient assessment via phone or telehealth. Alternate prenatal care scheduled. Women with suspected or confirmed COVID infection should notify the obstetric unit prior to arrival to allow for appropriate infection control procedures. Initial administration for suspected COVID-19 in pregnant women should be administered based on the severity of symptoms and the clinical social risk factors. Antenatal consideration, antenatal fetal surveillance during acute illness fetal management should be similar to that provided to any critically ill pregnant person. Ultrasound. Elective ultrasound exams should not be performed if a risk of exposure and increase within the community is greater than benefit of testing. Consider postpone for canceling some testing or exams. Detailed middle trimester anatomy ultrasound examination may be considered following first trimester maternal COVID-19 infection. Ultrasound assessment of fetal growth is indicated in pregnant women with COVID-19 infection due to risk of fetal growth and restriction. All pregnant women with suspected or confirmed COVID-19 infection should receive the prophylactic low molecular weight heparin upon administration, reduce the risk of venous thromboembolism unless birth is expected within 12 hours. Antenatal corticosteroids for fetal maturation for pregnancies with suspected or confirmed COVID-19 between 24 plus 7 weeks and 33 plus 6 weeks gestation, at which for preterm birth within 7 days antenatal corticosteroid should be continued to be offered as a recommendation. For pregnancies between 33 to 36 weeks plus 7 day gestation risk for preterm birth within 7 days antenatal corticosteroid should not be offered. Modification to care should be individualized, weighting neonatal benefits or neonatal antenatal corticosteroid with risk of potential harm for possible immunosuppression in infected patient. Benefits of magnesium sulfate or for fetal neuroprotection should be weighted against the potential risk of maternal respiratory depression in the patient with symptoms of infection while also taking gestational age in account. Labor and delivery general consideration for labor and delivery rate cord clamping is still appropriate in the setting of suspected or confirmed COVID-19 infection with use of appropriate personal protective equipment. Scheduled indications for labor and cesarean delivery should be continued to be performed and indicated with consideration made to availability of health personnel and access to readily available resources. Number of visitors should be limited during in-hospital maternity care, minimizing the risk of infection. Setting and mode of delivery, timing of delivery should not be affected by COVID infection in the most cases. Cesarean delivery should be based on the obstetric fetal monitoring indication and not based on suspected or confirmed COVID infection. No intrauterine infection be vertical transmission reported in women with COVID-19 in late pregnancy. Maternal and fetal monitoring should be continued by standard practice with some additional consideration for women with suspected or confirmed COVID-19 depending on the severity of symptoms. Postpartum management tubal sterilization other than that performed during cesarean delivery is an elective procedure. Therefore, postpartum tubal ligation should be deferred in the patient who are COVID-19 positive and alternative forms of contraception can be offered. Initial neonatal assessment and management infants born to mothers with confirmed COVID-19 should be considered personal under investigation and should be isolated per United States Center of Disease Control and Prevention CDC guidance 2019 April. Assessment and management of neonatal born to mother with suspected or confirmed COVID-19 include clinical assessment including COVID-19 testing to determine the need for necessary administration, mother-infant contact, decision whether to separate mothers with suspected or confirmed COVID-19 and her infant should be made on case-by-case basis using a shared decision-making between the mothers and the clinical team. Enrooming in of the mothers and the newborn occur in accordance with mother's wishes or it's unfavorable due to facility limitation. Considered implementation measures to be reduced exposure of the neonate to COVID-19. Expedited discharge from the hospital may be considered when both mothers and the infant are healthy to limit the risk of exposure and infection to COVID-19. Allow women with confirmed COVID-19 should be given by prophylactically low molecular weight heparin for 10 days upon hospital discharge regardless of the mode of the birth. Consider the modify of the reducing postpartum follow-up appointment to decrease the risk of COVID-19 spread and exposure. Breastfeeding for women with suspected or confirmed COVID-19 for mothers with infant bears who are roaming in breastfeeding can be considered with uses of proper hand washing and other preventive measures to decrease the risk of exposure for the infant. For mothers and infant bears who are temporarily separated, mothers who wishes to breastfeed should be encouraged to express their breast milk to establish, maintain a milk supply and decrease the milk should be fed on newborn by health care giver. Many thanks for my audience.